Uh, okay, we'll discuss hormonal replacement therapy. Uh, there's a lot in hormone replacement therapy, but in this case, we are discussing menopause. So hormone replacement therapy or menopausal hormonal therapy involves the administration of estrogen and progesterone to replace a woman's depleting hormone levels. So it starts with the perimenopause, also known as the menopausal transition or the climacteric. It starts 3 to 5 years. That is basically perimenopause is 3 to 5 years before menopause and 1 year after menopause. This includes changes in ovarian secretion of reproductive hormones due to decline in oocyte quantity and quality, thus resulting in changes in menstrual patterns. Menopause. Menopause is a retrospective diagnosis. It is a diagnosis that is made after you have had 12 months of amenorrhea. And this signifies the depletion of ovarian follicles and the diminution of ovarian hormones. It occurs at a mean age of 51 to 52 years. There are no independent biological markers, and the end of menstrual cycles is used as the hallmark of menopause. So there is no need to repeatedly do SSH, AMH levels, and ultrasounds or anything else to diagnose menopause. So in principle, and this is very, very important to remember, in principle, the depletion of estrogen is not only the end of reproductive life. It triggers a multi-organ, multi-system dysfunction in women that compounds the aging process. It has been something of a mystery and somewhat a discovery um, that estrogen receptors are present in almost every organ and every system of the woman. And these are the multiple changes that occur in multiple systems in a woman, starting from CNS, vasomotor symptoms, sleep disruption, depression and anxiety, cognitive changes, migraine, skin changes, reduced elasticity, reduced hydration, increased wrinkling, hair loss. This has got to do with the body image, the confidence. Weight and metabolic changes, increased weight gain, increased androgenic type of weight gain, that is visceral adiposity and waist circumference. There's in the musculoskeletal system, there's loss of bone mass density. There's a decrease in muscle mass, joint pain, sarcopenia. There's a change in sexual function, decreased sexual desire, decreased libido, dyspareunia, and that could be associated with changes in the urogenital system. There's vaginal dryness, there's valvular itching and burning. There's also a whole range of lower urinary tract symptoms, dysuria, urinary frequency, urgency, and recurrent lower urinary tract infections due to the change in the microbiome as well. Now, there's a whole change in the endocrinal milieu in the women's body. And of course, it starts with the decrease in inhibin B, increase in SSH, LH, decrease in estradiol progesterone, and the decrease in the androgenic or testosterone production as well, DHEA and DHES, and also decrease in the beta endorphin. And in contrast, there's an increase in cortisol, and there's an increase in the sympathetic system hormones, noradrenaline, and there's an increase in C-reactive protein. This puts our body and our systems under continuous stress, a continuous inflammation that leads to remodeling of the systems and adaptation of the body to that continuous stress. And that leads and that compounds and that all adds on to the deleterious effects of aging. So largely divided them in early symptoms, middle symptoms, and lead problems. I have really not gone into the classifications, the stroke classifications, and because those are difficult to remember, they are table based. I would like to go having put some message forward, and for us to remember what is important clinically. Okay, so early symptoms can be hot flashes, mood swings, anxiety, sleep disruption, fatigue, sexual dysfunction. Symptoms that are prominent in the middle years between mid-50s to mid-60s are urinary incontinence and dry skin. The patient survives and is healthy. Then we have worse problems entering the picture: osteoporosis, cardiovascular events, cerebrovascular events, and dementia. So, should we advocate for HRT? Yes, we need to advocate for HRT so that we can rewrite the dynamics of the aging process. So why HRT? Because it alleviates premenopausal and climacteric disturbances due to the hormonal changes and instabilities. The premenopausal and climacteric disturbances have a huge impact on the woman's body image, on the woman's psychological state, and thus having an impact on later on dementia and weight gain and metabolic changes as well. HRT is a preventive measure and also therapeutic. Okay, so we have known HRT as a preventive measure, as a measure to alleviate climacteric changes. But now there is increasing evidence that it is therapeutic for menopause and aging. Newer products, reduced doses, newer routes of administration reduce the negative outcomes, increase adherence, and increase the positive outcomes of HRT. And that's why we should be bringing it in. We should be talking about it, and we should be moving towards managing our patients with HRT. Longer life expectancy calls for an improvement in the quality of life. Improvement in the quality of life means less expenses as well towards chronic illnesses. So types of MHT, so it can get confusing because there's so much going on. There are new compounds in the market, there are new combinations. Okay, so I'll just briefly cut it down and discuss the hormones very briefly, of course. So dependent on the hormonal combinations we are using, we can have estrogen only or combined estrogen and progesterone, cyclic or sequential. We can have androgen as hormonal replacement therapy as well, and I'll explain why. We can have testosterone, we can have DHEA. Based on the compound, so there are different types of estrogens, and there are many types of progesterones. So there's conjugated equine estrogen, there's ethinyl estradiol, and estetrol in use. For progesterones, there are many types of classifications. I'll just simply put them that the most important in our case is on its mode of action. Mode of action, whether its mode of action is androgenic or whether its mode of action is, does it have an androgenic effect? Does it have a steroidogenic effect, a mineralocorticoid effect, or an estrogenic effect? Because that that will determine our choice of progesterone. And the route of use, we can use, there's the oral route of use of hormones. We can have transdermal use of hormones, meaning in terms of patches or gels or even sprays. And then we can have vaginal pessaries, or we can have creams for use in the vagina. And then we have implants containing hormones. So synthetic estrogens, ethinyl estradiol and mestranol, they are very potent and they enhance hepatic effects, which increases synthesis of clotting factors, angiotensin, and sex hormone binding globulin. And that's why they are used with a lot of precaution. And they're only used when we have premature menopause and the climacteric symptoms are out of control and we really need to bring them under control. So again, our choice of estrogen will also be determined by the effect on the load. And as we can see, 17 beta estradiol has the least effect, the least load on the liver, and CEE has the highest effect on the liver. As we can see, there are many, many progesterones. We need to study them. I just point out a few, right? The most, the nearest to the original progesterone molecule, the micronized progesterone and the dihydrogesterone. And we tend to use that a lot. That's why I'm pointing them out. And amongst these are the many other estrogens with effects either related, either steroidogenic effects or androgenic effects or mineralocorticoidic effects. And then we have this spironolactone derivative, drosperinone, which has an anti-mineralocorticoidic effect. Okay, so again, having a chart like this, which tells you uh, which hormone has what kind of effect, guides you and helps you towards choosing the right progesterone. Okay, so androgens, just a small reminder, we tend to forget this, right? DHEA is produced equally by both the ovary and the adrenal gland, and so is androstenedione and testosterone. But DHEA is also interchangeably a product of DHES, which is produced by the adrenal gland, right? Mostly by the adrenal gland, 80% in the body, and it's not produced by the ovary at all. Okay, so DHEA is a precursor for both estrogen, testosterone, and even progesterone. DHEA reverses the rise in cortisol to a certain extent and thus overall reduction in inflammation. If you remember, a few slides back, we discussed how cortisol rises in menopause and thus the body goes into an inflammatory mode with the rise of cortisol. Now, this is the production of DHEA. It's the highest in the 20s in both men and women. Women is in yellow and men is in green, right? And then it subsequently gradually declines until the 50s, and it's almost half by mid-50s. By mid-50s, it's almost half the value of what it was. Cortisol, on the other hand, rises, okay? Rises from the mid-20s all over up to your 50s, and it's almost double the concentration, and it's equal in both men and women. So DHEA and cortisol are kind of antagonistic. If there is increased DHEA in your body, then cortisol goes down. And if there is high cortisol, then DHEA goes down. So this is something that is not yet well understood, but it gives us an idea that with increased DHEA in the body, at least we'll have low cortisol and thus lower inflammation. DHEA converts to allopregnanolone, which is a neurosteroid in the brain, and this helps in stabilizing mood disorders and sleep disorders. DHEA has also got a positive effect on glucose metabolism through an increase in beta endorphin. Okay, so DHEA is a precursor for androgens and estrogens in the body. It becomes the primary source of both estrogens and androgens after menopause, or basically the only source. SERMs are also in the market and are also used for menopausal hormonal therapy, selective estrogen receptor modulators. Okay, now SERMs are selective estrogen receptor modulators because they have a positive or agonistic estrogen effect on some estrogen receptors and a negative or antagonistic effect on other estrogen modulators. And it actually depends on the type of SERMs you're dealing with. So tamoxifen has got an antagonistic effect on the breast and agonistic effect on the uterus. So it has got an estrogen agonistic effect on the uterus. So it is an excellent for those who are at high risk for breast cancer. However, it can give us endometrial hyperplasia and in some case even CA endometrium. We can also have polyps and we can have cystic changes in the endometrium. A serious side effect of tamoxifen is DVT. So if we have history of thromboembolic disorders, then tamoxifen is ruled out. Raloxifene, a second generation SERM, has an estrogenic agonistic effect on the bones, has an antagonistic effect on both the uterus and the breast. So we can, we can clear out endometrial hyperplasia, formation of polyps, and even CA endometrium. It has a good metabolic profile. It increases HDLs and reduces LDLs. It is also under study for use in postmenopausal women with schizophrenia. So we can see that the positive action has a wider profile, a, a better profile. And the most serious side effect is again deep venous thrombosis. A newer drug in the market, osepemifen, significantly improves the structure and pH levels of the vagina, reducing dyspareunia. It has an estrogen agonist action on the bone. It reduces proliferation of ductal cell carcinoma in experiments. Anti-estrogenic effect on the uterus and endometrium. Of course, it's contraindicated on thromboembolic disease. It is currently under investigation for use of the genitourinary tract menopausal symptoms as an HRT in the genitourinary menopausal symptoms. Now, one thing to note about SERMs is if any of your patients is on SERMs and is supposed to go under any surgery, then they need to stop the medication, the medication 3 weeks prior to surgery to reduce the incidence of thromboembolic disease. Tibolone. Tibolone is a synthetic steroid which has estrogenic, progestogenic, and androgenic action. The drug is metabolized into 3 active metabolites, 2 of which bind solely to the estrogen receptor, and a third which has affinity for the progesterone and androgen receptors. So it gives us good estrogenic effects that are exerted in the bone, in the vagina, and help control vasomotor symptoms. And it has got progestogenic effects which prevent endometrial hyperplasia. And it has got androgenic effects which are great for sexual health. Okay? And it has got minimal effect on the breast tissue. So this is an excellent drug to use for HMT. Okay? So again, the benefits of menstrual hormonal therapy, I'm just sharing the picture to remind us the multi-organ, multifactorial adverse effects of menopause, and just to bring it forth that menopausal hormonal therapy has a positive effect on all of the above and more. So risks in menopausal hormonal therapy, there are cardiovascular risks, arterial events, MI, new angina, transient ischemic attack, or a stroke. And then there are venous events, DVT, and pulmonary embolism. There's a risk of breast cancer. There's a risk of endometrial cancer in estrogen-only therapy, women with an intact uterus. And there's a risk of endometrial hyperplasia and other changes in the endometrium like polyps and cystic changes. Other risks involved are gallbladder disease due to the effects on the liver, especially when we're using oral hormonal therapy with the first pass in the liver. Increased risk of dementia when started in older women, although this is being debated. Other effects that could hamper hormonal therapy is weight gain, breast tenderness, migraines, breakthrough bleeding, etc. So What we need to do in this instance, right? We need to weigh our benefits, right? We need to really look into and see how we can focus on maximizing our benefits, our positives with minimal side effects. Now, how do we do this? We have to know our patient well, right? We have to know our patient well. We need to do a thorough assessment of the patient. We need to get their menopausal systems. We need their menopausal symptoms. We need to get all our gynecological factors in. We need to look at the bleeding pattern, the menstrual cycle, whether the person is post-surgery, whether it's a surgical or an iatrogenic menopause, whether there's any current use of hormonal therapy, whether the patient needs contraception or not, the dietary history, sleep history, sexual history of the patient, the sexual health of the patient, whether the patient has got continuous premenopausal symptoms, because if the patient is one who gets PMS and has to be managed for that, then definitely we're going to deal with a roller coaster of a climacteric period. If the patient had any postnatal depression, because again, that gives us an idea of the psychology of the patient. We need to do a personal assessment of the patient's medical history, the assessment of the risk assessment for diabetes, for hypertension, for DVT, for thyroid functions, for liver disease, for osteoporosis, arthritis, climacteric depression, dementia, cancers in general, but specifically, we have to assess for breast cancer, cervical, ovarian, and endometrial cancer. We need to take a comprehensive family history, look into cardio and cerebrovascular diseases. We need to look into a family history of osteoporosis, fractures, dementia, and cancers. We need to look into the current medication the patient is, including over-the-counter medications, and we need to know the allergy profile, the drug allergy profile. We need to look into social and the personal history of patients. We need to look into their social status, into their marital status, into their sexual activity. We need to look into tobacco, alcohol use, or any other social drugs that are used. We also need to take into consideration geopolitical dynamics and socio-cultural dynamics. Okay? We need to individualize the treatment of the patient, choose the best route of administration of the drug, and optimize dosing. Okay? We need to remember that no one size fits all. For the purposes of dosing, for hormones, and we know for all hormones, for thyroxine, whether we are doing a hormone replacement in thyroid or hormone replacement, insulin hormone replacement, whatever hormone replacement you're doing, too much or too little can be deleterious for the patient. So we need to get the optimal dosing, and with that we'll have beneficial effects. And we need to do a good follow-up of the patient. Okay? And that's why we need a comprehensive approach. We need a multidisciplinary team. Do we have these? No. At the moment, no. But we need to be in constant touch with the physician, with a geriatric doctor, with a psychiatrist, with a cardiologist, with a diabetologist, to be able to choose the right drug, optimize your dosage and your route of administration, and be able to discuss the benefits with the physician and with the cardiologist. Otherwise, where we are at the moment, the patient leaves your office, goes for the next appointment to the physician, and the MHT is stopped, right? So we also need to educate others. So effects of HRT on CVS, very briefly. So the International Menopausal Society has issued a consensus statement since 2009 that HRT can be given to women around the age of natural menopause glucose without increasing the risk of coronary heart disease and may even decrease the risk in this age group. Several years later, we know that it does decrease the risk in the age group. It does decrease the risk of uh, coronary heart disease. HRT is not contraindicated in women with hypertension and may even reduce blood pressure in some cases. For example, if we use drospirenone, which has an anti-mineralocorticoid activity, as our progesterone of choice with estradiol, then we can even reduce the blood pressure. HRT is contraindicated in women with a history of myocardial infarction, stroke, or pulmonary embolism. Now, these are some studies that show the use of estrogens and the effect on lipids. So this is CEE, the use of CEE. The reds are in the use of the reds represent CEE in different doses. The greens represent estradiol in different doses, and the blues represent transdermal estradiol. So these two are orals, and this is transdermal. So the advantage of using transdermal estrogen is that it bypasses the first metabolism in the liver. The disadvantage is the fact that it doesn't act on the liver. So we don't get the effects that come from the synthesis and the bioproductions that occur in the liver. Okay, so as we can see that all estrogens, CEE, estradiol, both oral and transdermal, do reduce cholesterol. We can see that the transdermal estradiols reduce cholesterol more than the orals. All of them significantly reduce LDL, and all of them increase HDL, right? However, there's this inadvertent action that all the oral estrogens increase triglycerides significantly, and the transdermal estradiol reduce triglycerides. So knowing this can help us to determine in certain patients having a lipid profile, having assessed their risk of cardiovascular disease, cerebrovascular disease, thromboembolism, and having the lipid profile and having this knowledge will help you to determine the best estrogen to use for HRT. Okay, again, this is now a comparison of using CEE and CEE combined with cyclic norgestrel. We know that norgestrel has an androgenic effect. It has an androgenic effect on it has an androgenic effect on metabolism. So we can see that CE alone reduces cholesterol, has increases triglycerides, reduces LDLs and their carrier protein, and reduces HDL and their increases HDL and their carrier protein significantly, which is a very positive effect. So a combination of CEE with norgestrel reduces cholesterol significantly. It reduces triglycerides, it reduces LDL and its carrier protein, but also reduces HDL and its carrier protein. So progesterones that have an androgenic effect tend to reduce HDL. Okay, so another study comparing estradiol 2 milligrams alone and is cyclic estradiol with dydrogesterone. Okay, so again, estradiol alone reduces cholesterol, increases triglycerides. This is oral estradiol, and reduces LDL and increases HDL, right? Combined with dydrogesterone remains more or less the same and increases HDL, and also triglycerides remain the same. So this gives us an idea that dydrogesterone doesn't have a deleterious effect on metabolism. So HRT and glucose and insulin, CEE in very high doses gives us impaired glucose tolerance and impaired insulin response, but at lower doses has no effect on glucose tolerance. Oral estradiol gives us improved glucose tolerance and improved insulin action as well. Transdermal estradiol gives us the same effect as oral estradiol, but to a lesser extent. So again, it's because of oral estradiol goes through the first bypass through the liver, and thus acts on SHBG and acts on uh, the metabolic effects of insulin. Progesterones, oral progesterones, which have an androgenic action, have a negative impact on glucose metabolism and the increased insulin resistance. Transdermal androgenic progesterones have little or no negative effect on either glucose or insulin. Dydrogesterone and micronized progesterone have no effect on glucose metabolism. HRT and body fat composition, I think this is a huge stigma. I don't want hormones, I'll put on weight. So there is no increase in total fat, and there's a relative decrease in android fat with use of HRT. And this is a graph from the WHI study, okay? A 3-year follow-up, right? On those who are on placebo and those who are in the hormonal treatment arm. And it shows that those who are on placebo added more weight than those who are on any form of hormonal treatment. So we've discussed this, that HRT usually does not have an effect on blood pressure, and you can have a better effect if you use drospirenone, which has an antimineralocorticoid effect. Okay, I just want to draw your attention to this study that used estrogen in different forms and estrogen with different progesterones, and the odds ratio and the highest risk. Okay, so for uh, DVT or for venous thromboembolic events. So CEE plus MPA had the highest odd ratio, that is the highest risk, more than 2 for thromboembolic events. Again, MPA and oral CEE, MPA has an androgenic effect, so it has a deleterious metabolic effect, and CEE we know has a very high thrombogenic incidence. E2, that is estradiol plus dydrogesterone, had the lowest odds ratio, almost equal to 1, right? And transdermal estradiol and any other progestin had no increase in the, had an odds ratio of less than 1. So no increase in the risk of thrombogenic events. Okay, so GSM or genitourinary symptoms of menopause. I think I'll keep on saying GSM because it's a mouthful. So two sides of the same coin, vulvovaginal atrophy and lower urinary tract dysfunctions, both coming together. So, you know, we have not been attributing the lower urinary tract dysfunction to lack of estrogen or to hormonal depletion generally, and we have been attributing that to aging. But it's increasingly evident that a lot of the lower urinary tract organs and receptors are dependent on estrogen. So with reduction in estrogen levels, we get urogenital atrophy, and there's thinning of the skin and atrophy of the subcutaneous fat. There's atrophy of all other estrogen-dependent tissues, and this is the pelvic floor muscle and bladder and urethral functions are also affected by this. There's decreased continence mechanism, decreased urethral resistance, and the decreased sensory threshold. Sorry, or increased, yes, decreased sensory threshold. And then there's also alterations in the microbiome because of the alteration of the vaginal pH, and that results in, continuous or recurrent chronic urinary tract infections. Now, I just want to bring to our attention that all the structural changes that occur in the genitourinary system across menopause, right? Only the ones highlighted in green are estrogen dependent, and a lot of others are androgen dependent, right? Remember, right from embryogenesis, the genitourinary system arises from the ectoderm, right? And a lot of it is androgen dependent and specifically dependent on dihydrotestosterone. So postmenopausal lower urinary tract symptoms, you can have a painful bladder, recurrent UTIs, overactive bladder, incomplete bladder emptying, urge and stress incontinence. And when we get this, because our urogynecology is even weak, we tend to, and it's always dynamic and evolving, we tend to get confused and uh, we don't think of menopause, we don't think of hormone depletion, and we rush for surgeries and we rush for other chemical compounds. So estrogen therapy for your lower urinary tract, uh, a Cochrane review revealed that there's moderate quality evidence supporting vaginal estrogen therapy in the treatment of urge incontinence and recurrent UTIs. So you can use pessaries or you can use creams and gels. There is low or very low quality evidence supporting the use of vaginal EP for improvement of dysuria, urinary frequency, urgency, nocturia, and stress incontinence. I would like to believe that this is because there is also little research, proper studies in the same direction, and there needs to be more research in that. So local estrogens, pessaries, creams are used, and progesterone at this point is not required to counter its effect on the endometrium. DHEA and occasionally low-dose testosterone are also recommended for urogenital symptoms, as well as for management of libido. So DHEA, there's a 6.25 milligram pessary that can be inserted into the vagina, and it can be used for about 3 months to help, improve the sexual health of a woman. Tibolone 2.5 milligrams per day for 6 months in postmenopausal women with vaginal atrophy has significantly shown to improve vaginal dryness, dyspareunia, and signs of atrophic vaginitis without causing endometrial proliferation. Ospemifene, the latest drug in the market, is an oral drug, and it is dispensed in 60 milligrams, and it can be used as one tablet per day for 12 weeks to reduce vaginal atrophy and improve um, the sexual function of the lady. MHT and osteoporosis. So the WHI showed an overall reduction in all fractures in patients with patients with on menopausal hormonal treatment. So, just a brief. The WHI had three arms. There was a placebo arm. There was an arm which had supplementation, calcium, vitamin D3, and dietary modifications. And there was the hormonal therapeutic arm. So the hormonal therapeutic arm across all the combinations demonstrated a significant reduction in all clinical fractures during the intervention phase. Cumulatively, over 13 years of follow-up, women assigned to estrogen and progesterone had a 29% significantly reduced risk of hip fracture. And in the estrogen-only group, there was a significant 9% reduction in hip fracture. So we can see the difference. Estrogen plus progesterone had a 29%, and estrogen only had a 9% reduction in hip fracture, right? So we can see this reduction in all fractures. Now, we can see that the reduction in the CEE plus MPA was, of course, higher. And that could be because MPA has got an androgenic effect, right? And that could help improve the bone and the muscle mass. Now, the bone mineral density content in menopausal women has a kind of a reversible effect, right? And this was demonstrated in a study for 3 years where there were two arms of randomization, right? The first one in blue was given estradiol with a progestin with no testosterone, progesterone for 2 years, right? And the placebo one, um, who didn't get anything. So after 2.5 years, there was a randomization, and those who were who continued the therapy, right? There was a randomization, and some continued therapy and some dropped therapy. So those who continued therapy had a better BMD, and those who dropped therapy, there was a reversal in the BMD, in the bone mineral density. And the same goes for placebo. After 2.5 years, there was a randomization, and some started the combined therapy, and some continued the placebo. So for those who were on placebo, they continued to lose the bone mineral density, bone mineral mass, the bone mass, and those who started therapy had an increase in their bone mineral mass. And thus, uh, there's a very positive effect of combined therapy on the bone mineral mass, and the effect is reversible. And this is something that we need to remember. So effect of different types of hormones on or different types of bone metabolites on bone mineral density. So we can see that a combination of estradiol and nortestosterone had the best outcome for bone mineral density on the spine, and I can say a little significantly on the hip and on the total body as well. A combination of estrogen and MPA had a still better response than 5 milligrams of alendronate and 2.5 milligrams of alendronate. However, all had a better response in comparison to placebo. Okay, so again, a comparison of estrogen doses and the way they are taken. Okay, and we can see that all estrogens, right, uh, low dose, high dose do have a positive effect on bone mineral density, even the smallest effect, but there is an effect. The thing is that as long as we maintain our estrogen levels above 5 micrograms, then we are going to get some kind of protective effect on our bones. And the therapeutic levels would be between 35 and 65. Okay, so now this is transdermal estradiol against placebo. Again, there's a good protective effect, especially in the lumbar spine, slightly reduced, but still significant effect in the hip. So this is from the WHI. Like I told you, there were three arms. There was the placebo arm, there was the arm that had vitamin D and calcium supplements, and the arm that was on hormonal replacement therapy. And this is the assessment of risk fractures. So we can see that there's a significant reduction in risk fractures on the arm that is on hormonal therapy. This is the arm that was on calcium and vitamin D and dietary modification. So we can see that there is still a reduction in the incidence of fractures in comparison to placebo. And so we would say, let's do HT and let's do calcium, vitamin D, and also let's do lifestyle modifications. Therapy with tibolone significantly increases bone mineral density. So this was in various parts of the body. And this is tibolone and this is placebo. And we can see that there's a significant increase in bone mineral density. SUMS, that is tamoxifen and raloxifene, are ideal in women with higher risk of breast cancer and vertebral fractures. Again, increase in bone mineral density in the lumbar spine and in the hip on use of tamoxifen. So, management of climacteric syndromes, vasomotor, cardiovascular symptoms. So most of the climacteric symptoms are the early symptoms of menopause. We discussed them earlier, the vasomotor or the cardiovascular ones, CNS, difficulty in sleeping, mood changes, dysphoria, difficulty in concentration, memory lapses, emotional changes, musculoskeletal changes, of which the leading symptom is joint pains and backache. Urogenital, urinary urgency, nocturia, reduced sexual drive, dyspareunia, and miscellaneous, all to do with skin, hair, nails, and touching the body image. So use of transdermal estrogen with a combination of NETA still gave us a good effect in reduction of hot flushes. So depression in menopause, there's increased vulnerability during menopausal transition and early menopause. There is evidence that in menopausal transition, estrogen replacement leads to a significant amelioration of symptoms. And there's an evidence of synergetic effect between estrogen and antidepressants. There's a study done on patients who are already on fluoxetine and use of estrogen and randomization with concurrent use of estrogen and placebo. And those people who used estrogen with the same dosage of fluoxetine did much better than those who did not use estrogen. There's not much effect of estrogen on depression in late menopause, and there is evidence of neuroprotection on early initiation of MHT, meaning cognitive function, dementia, and Alzheimer's. So we need to actualize HRT. And how do we go about actualizing HRT? So let's not miss the window of opportunity. The best time is to start as soon as menopause sets in, or at least under the age of 60. That way, we maximize the beneficial effects. We take advantage of the preventive effects of MHT, right? The advantage of prevention of CVD, prevention of CPS, and increase of bone mineral density, and retaining cognitive function. You need to know your patient well. I can't, overstress this. Consider your patient's preferences. There are women for whom their body image is extremely important. There are women for whom their sexual function is extremely important. There are women whose, whose finer motor skills are very important. For example, like us, gynecologists, laparoscopic surgeons, gyne-oncologists, generally surgeons, right? Beauticians, and those people need to keep those intact. And what are the hormones that will help keep the psychomotor function intact? So this is very important. Know your hormonal compounds, their interactions, the route of use, and the side effects well. Counsel your patients. Counsel them on the side effects. Counsel them on breakthrough bleeds. Counsel them on the importance of adherence. Counsel them on reversible effects. Okay? Tailor the therapy according to phenotype, body type, underlying comorbids, age, and cause of onset of menopause. Whether it's surgical, whether it's premature ovarian failure, or whether it's an oncological patient. We have to take many considerations if we're dealing with an oncological patient. In in surgical menopause, the onset of climacteric symptoms, the hot flushes, the effects on libido, the effects on the psychology are immense, and thus we need a higher dose, and we need multiple compounds to try and bring that under control. Weigh the risks and benefits carefully, always keeping in mind VTE safety, consider contraindications and risks related to therapies. Tailor the therapy using the widely available compounds and doses, keeping in mind patient needs and preferences. Educate your patient well. MHT is not a replacement of lifestyle interventions, but integrative. And in conclusion, healthy aging, again, is a compound or an integrative management, and as a result of many other changes. So apart from hormones, which do play a major role, we need to have a good diet. We need to modify our diet. We need to modify our habits. We need to increase physical activity. We need to keep up with social and mental activity to keep our psychology and cognitive functions in place. Thank you. Thank you.
Thank you, Dr. Hafsa, for that wonderful, detailed, and informative presentation. We feel more empowered now. Now I'd like to invite questions, comments, additions. I don't see anything in the chat box yet, but if you have any question, feel free to raise your hand, and we will unmute you and give you a chance to ask your question. Any comment, question, clarification? We have few comments in the chat box. Amanda, thank you for the fantastic presentation. I agree. Thank you for that presentation. Could you please clarify the slide on tamoxifen? Dr. Hafsa, we have a question. Could you please clarify the slide on tamoxifen?
Okay. If I can ask, what specifically?
Dorcas Mushiri, maybe you could tell us specifically what you would like the presenter to clarify on tamoxifen?
I'm not sure you can hear me very clearly on the transit. I just wondered, I was confused about where it is placed above ozempic. Is it suggesting that it is HRT, or was it just like highlighted things that should be used?
Sorry, I can't get you.
Kindly,
So,
Dorcas, if you could repeat yourself.
Sure, if you can hear me, I'm in transit.
Yes, I can hear you now.
Okay, all right. I just wondered about the placement of tamoxifen on that slide, and whether you're suggesting that it can be used as a HRT, or was it just as part of SERMs? Because at the bottom there's osemphine, which can work as a HRT, but I'm not sure about tamoxifen.
Okay, so tamoxifen can be used in some instances, right? You know, and this was a comparison. Tamoxifen, those at highest risk for breast cancer might actually be better off with tamoxifen because it has the best profile of protection in comparison to both raloxifene and ozepimifene.
Thank you, Dr.
But then,
Hafsa.
Ozepimifene is a new drug. It's the one later on. So tamoxifen has been used. Raloxifene has an anti-breast CA effect, but on a lesser scale.
yeah, so my question was, is that in relation to HRT, or is it tamoxifen because they are breast cancer patients? That's what I want to clarify.
Well, it could be both ways. It could be that, you know, you have a patient who is at high risk for breast cancer. It's already being used as a preventive therapy for breast cancer, right? But it is increasingly being abandoned because, you know, raloxifene has a better has a better effect on the uterus. This is not indicative, or the explanation is just about what tamoxifen is and where it can be used. But yes, you can use it in patients who have had breast cancer, and you can use it in patients who have had hysterectomy. You can use it in patients who are at risk of breast cancer.
Okay.
And as an HT as well.
Okay, thank you.
Okay, another question from Huela. For patients with primary ovarian insufficiency, what is the recommended duration of use of HRT? What is the recommended duration in patients with primary ovarian?
Ideally, you need to use it until, you know, onset of physiological menopause, because you're going to be using slightly higher doses, you know, and you're going to be using a compound of substances, you know, to retain the function of the woman, right? So ideally, up to around the age where physiological menopause is supposed to set in, and then you reevaluate. So the present mode of thinking is, you know, you'd say initially when we look into hormonal replacement therapy, we'd say, okay, use it for 3-4 years, then evaluate if, you know, if symptoms have subsided, you reduce the MHT, right? So the present mode, or the present ongoing discussions are looking into why stop MHT. If the patient is doing well, right, has no serious side effects, and wants to continue the MHT, then let them continue as long as we're not having any adverse effects. Because as we can see, some of the positive effects are reversible over time.
Okay, I believe according to the WHI, the Women Health Initiative, they recommend the use up to 60 years of age. But again, you'll also look at the symptomatology. You might have to use it a bit longer.
You have a positive effect if you start before 60 years of age.
Yes, this is for those with primary ovarian insufficiency, that until the age of 60 years, then you reevaluate. Okay, another question is routine endometrial sampling recommended for patients with menopausal hormone therapy if they have no symptoms?
No.
Daniel Kyoko?
No, routine is not recommended. Routine is not recommended. You will use your normal follow-up unless you know you're using a compound that has got an estrogenic effect on the uterus. That is, if you're, you know, I mean, for example, if you're using tamoxifen, right? Then you will need to keep on evaluating your uterus, okay? But if you're using a combined therapy, then progesterone is giving you the anti-androgen effect on the uterus, and you don't need to evaluate,
Okay.
right?
Another
And
question.
you need to also be using, you need to be also using the right dose of progesterone. So, if sometimes you are underdosing progesterone, then you're going to get breakthrough bleeds and you're going to get endometrial hyperplasia. So that is something that you need to take care of. So,
Thank you. Another question from Dr. Nyongesa. The hardest part on an African woman is when she is told she will start getting menses like bleeding. How do you go about counseling these women?
okay, I understand this, and in relation to the fact, the risk of cervical cancer and all this, right? That you tell them you might get a bleed, right? It's if you're doing continuous, you kind of do cyclic in the initial years, and then after that you go to a combined continuous management of or use of compounds which have uh, both estrogen and progesterone, and you're using them continuous. Now from there you might get breakthrough bleeding, right? And you can tell them that yes, it happens, but if it is affecting your lifestyle, right? And if you think that it is anything unusual, then please come in for an evaluation.
And I believe this is where the concept of counseling and patient's education comes in, not just starting the treatment blindly. So again, you have to weigh the risk versus benefit and make the patients well informed, and then you make the decisions together. Okay, on another question from Dr. Nurain. For the patient post bilateral salpingo-oophorectomy for whatever reason, and in, let's say, those who are 44 years, is that an indication to start HRT, or are onset of symptoms the guide for initiation?
Oh, surgical menopause is an indication to start HRT. Surgical menopause is an indication to start HRT. You don't wait for symptoms to set in.
Thank you.
Because it's the sudden loss.
Yes. Another question, any recommended schedule for screening for gynecologic cancers in women on HRT?
Routine screening. Unless there's a higher risk.
Okay. And do you recommend we start HRT for all menopausal women?
See, again, like I said, no one size fits all, right? It depends on the patient, right? It depends on the symptomatica they have. It depends on their risks. And it depends on whether they want to. But ideally, with all the positive effects, we should be able to do that, especially with with the increased life expectancy. You would want them to have a good quality of life, right?
Yes. Thank you. There's evidence that SSRIs can be used to control climacteric symptoms. Should we be starting with them prior to hormones in view of the side effects related to the hormones?
Well, if we are going to start the SSRIs, we are going to treat the climacteric symptoms. If we are going to start MHT, there's a whole profile of positive, positive outcomes that we have with the initiation of MHT. So again, I'd like to emphasize that we are moving away from just giving MHT for the purpose of controlling hot flushes, and moving to giving MHT as as an aid to aging, as an aid to aging well.
Yes. From Dr. Hussein Al-Habib, is there any role for phytoestrogen like soy isoflavones in treatment of climacteric symptoms, especially vasomotor symptoms like hot flashes?
Ideally, there should be. You know, the synthetic estrogens and the synthetic progesterones are squeezed out of the same uh, how do I say, the what we call the bioequivalent hormones of the same products that the phytoestrogens and all that are made from. So ideally it should be, but of course it's not proven.
Yeah,
Clinical, evidence-based.
some literature talk of them. It's not evidence-based, but it's some of the agents being used as non-pharmacological ones that can be used for alleviation of such symptoms. From Nyongesa again, what do you mean by saying that unless there is presence of a higher risk as asked above? Maybe Dr. Nyongesa, you clarify on that. This question is in relation to which question? They're asking, what do you mean by saying that unless there is presence of higher risk? In relation to which question, Daktari? Is it in relation to your previous question or somebody else's question? It's about the issue of counseling of women who present with bleeding or menses-like bleeding after initiation of ART.
Okay, he's added here, giving HRT to
all
postmenopausal. Of course, like I said, that it's, for example, it's contraindicated in you know, those who have already had an MI or who have had like something like PE or a stroke before, right? You know, if we have you know, if we have a patient, for example, who is 50, who is you know, who has a BMI of, let's say, 40, right? Who has already, you know, who is diabetic, is hypertensive, we need to weigh, right? Who is also probably on anticonvulsants. So then we have to weigh, right? We have to weigh our options. We have to weigh what we will start with. If I were to start with, I would start with probably, you know, the transdermal estradiol patches with some micronized progesterone, all very low dose. Make sure you've treated the patient well, everything is under balance before you initiate any HRT. So this is what I mean by high risk.
Thank you,
If a
Dr.
patient,
Another question from Wilmina, where can we easily get the drugs on hormone replacement?
well, this is the elephant in the room. We don't have them. It is very difficult. It is very, very difficult. We only have, you know, 1 or 2 brands, and then we have some pharmacies bringing them down intermittently, and we are very, very limited, very limited. And this is what we should be lobbying for. This is what we should be lobbying for, that, you know, we need to get these drugs on board. So, you know, thing is, we need to make noise. We need to be able to shout out the pluses of HRT. And so, you know, you start a reactionary circle where now, you know, pharmaceutical firms and the pharmaceutical controlling boards and all that will want to bring in these things. We want to bring in this. The good news is that there is a comparative study that is going on presently on between a COC and an estradiol-based combination with the same progesterone and seeing the effects it has on menopause. if that turns out to have a positive outcome towards COC, then we are lucky.
And I believe the challenge is more with the estrogen-only compound. Recently, I had a patient whom prescribed estrogen following hysterectomy, and she really had to look for those drugs, and eventually she got one with both estrogen and progesterone. So we should lobby for this. From Dr. Nyongesa again, would you give hormone replacement therapy to a hypertensive woman?
Yes. Yes. It is not contraindicated. And that is a statement from the International Menopausal Society.
Yes, and you actually mentioned some of them actually help in lowering the blood pressure.
Yes.
From Dr. Alex Bosire, herbal meds for these ladies for wetness and libido, hot flashes. Which herbal meds for these ladies that can take care of wetness, libido, hot flashes?
Oh, Daktari, this is a big debate. Let's stick to the hormonal replacement therapy that can help in libido and wetness. By the way, there's a whole thing on sexuality and sexual dysfunction of the woman and how we can maximize the hormones, the benefits of the hormones. It's a whole long, whole deal, a whole lecture on its own. I couldn't put it in here.
Thank you. Which hormone therapy, menopausal hormone therapy drugs are available locally, and approximately what is the cost? Even Femostone availability is a challenge.
Well, there's Pimoston. There are some pharmacies in Nairobi. There's one in Mombasa that do import estradiol patches on and off. Like I said it. They run out of stock. The patient comes crying to you now, Daktari, what should I use? I got a pharmacy that was importing a transdermal estrogen, estradiol, and then I got a pharmacy that imported gel capsules after that. It's really a challenge. At least we have estrogen cream. We have DHEA, oral DHEA. So we are trying to juggle around that. So again, like I say, we really need to advocate for these drugs to come down. And like you said, the cost is a challenge, so that's why it's menopausal hormonal therapy at the moment is for those for the elite, basically.
Dr. Nurain, in order of your preferences, would you give estrogen alone, progesterone alone, or combined?
Okay, look, you wouldn't give progesterone alone. Sometimes progesterone only is used for climacteric symptoms, right? For hot flushes, and it has got a good effect. But you wouldn't give progesterone alone because you're not adding any value as such, right? You can give estrogen alone in a patient who has been hysterectomized, right? If a patient has not been hysterectomized, then I advise you to give progesterone as an antidote to estrogen, meaning in connection with the effects of the endometrium.
Yes. I don't see any more questions. We are now it's almost 8 p.m. It's an interesting topic. There's a lot to be covered. Okay, Dr. Nyongesa is asking me to wait. As Dr. Nyongesa is typing his question, maybe take home message from this presentation, from today's talk. is that estrogen only to be prescribed on hysterectomized women. For those with uterus and intact uterus, you use combined estrogen progesterone, or if you are to use estrogen only, you have to give interrupted progesterone at least 6 months after the use of the estrogen. We should know our patients well through detailed history and evaluation of the risks. We should know our hormonal compounds in terms of interactions, route of administration, and the side effects, weigh the benefits and the risks. We should not miss out the window of opportunity. Hence, we should start as soon as menopause sets in, or at least under the age of 60 years. And again, finally, counseling and patient education, very important in the component of management of these patients. Dr. Nyongesa has a question. In surgical menopause, can COCs be useful? I think you just mentioned about the trial. In surgical menopause, can COCs be useful?
It's still under debate. It's still under, we need good hormonal replacement in surgical menopause.
Dr. Rukia Ali, what is the role of supplements? Which supplement means like calcium, vitamin D, or asking what is the role of supplements?
So I think if you mean calcium and vitamin D, then I showed this graph. Okay, the bold line is this graph is from the WHI study, the Women Health Initiative, where there were 3 arms. Okay, one arm was randomized to receive the hormonal therapy, and the second arm was to get vitamin D, calcium, diet modification, and the third arm was placebo, right? So you can see that the hormonal arm had the least fractures, and the calcium and vitamin D arm did have a reduction in fractures, right? It was still lower than placebo. So they do have a role.
Thank you. Comment on hormone replacement therapy risks in patients who stop for like 20 years or so, then restart, especially estrogen. Is there any risk in patients who stop?
Of course, if because if you're 50 and then you're stopping for 20 years, you're starting at 70, there's definitely the risks will be higher, definitely. And like we say, in many, if started on much later on in life, then you do not get a protective effect against cerebrovascular incidences, right? Or cardiovascular incidences, or a protective effect against cognitive disorders, against depression, right? So it doesn't make sense to stop and start much later. With bone, there's a graph I showed that with the bone, there was a reversal. There was a reversal, and we saw that they were doing placebo, and then they started HRT, and they did well. But with other systems, there are higher risks.
Thank you. Rukia Ali is trying to elaborate on her question about the role of supplements in terms of things like Evanova Herbal with multivitamins.
Again, I would say that it's not evidence-based. That's one. Multivitamins, all multivitamins come in when we are not having a good diet, I would say. So if we think that we need to add in something over the top of our diet, then we can have multivitamins.
I don't see any other questions. A lot of appreciations and congratulatory messages from different participants on the excellent, elaborate, and informative presentation. I think at this point, we would like to thank the COGS branch, the presenter, Dr. Hafsa, for organizing this webinar. It's a very important topic, and we all feel empowered better than how we came in before we joined this webinar. So, as we mentioned earlier, this topic is quite broad. There are so many things to talk about, but Dr. Hafsa has really tried to summarize and sum up everything in a very short while. But maybe we'll have some follow-up presentations touching on the same. So thank you everyone for joining today's webinar, and have a good night. Dr. Hafsa, any parting message?
Let's actualize MHD. I think we can talk about it, but there's a lot of work that needs to be done. We don't have the drugs. They're very costly. We can only move forward if drugs are available and, you know, they are reasonable.
Thank you. So let's actualize it. Thank you, everyone. We can now leave the webinar at our own